Hello, good afternoon, and welcome. I'm Liz Popwell, the Chief Strategy and Transformation Officer for Stony Brook Medicine. And today we have a wonderful panel for you in honor of International Women's Day and Women's Month. We're going to talk about women's health issues. And women have a lot of unique challenges in certain conditions that can be prevented if caught early. And so we're going to talk a lot about women's health and women disease processes and how we can take a preventative view of that. I've got a wonderful panel for you today, and I'm going to let them introduce themselves. Dr. Burke, would you like to go first?
Hi, I'm William Burke. I'm the interim chair in the Department of Obstetrics and Gynecology. I also serve as the division director for Gynecologic Oncology.
Great, thank you. Dr. Blaber?
My name is Dr. Jennifer Blaber. I am one of the minimally invasive gynecologic surgeons here at Stony Brook.
Thank you. Dr. Choi?
Good morning. My name is Jennifer Choi. I am a maternal fetal medicine specialist here in Stony Brook.
Dr. Mann?
Hi, I'm Noelle Mann. I'm one of the non-invasive cardiologists here. I'm also the director of the Women's Heart Health Center, as well as director of cardio obstetrics, as well as the fellowship program.
Wonderful. Thank you. All right, so let's go ahead and get right into it. The first question I have is really around minimally invasive surgery. And I had the honor of being able to follow Dr. Burke actually through some of the procedures and learn about some of the innovative approaches that we have through minimally invasive surgery. Many procedures that we used to have were open and took much more response time, recovery time for patients. And now we can do a lot of things more invasively, minimally invasively for patients, and that helps them get back to life faster and recover quicker. So Dr. Blaber, can you please explain what minimally invasive procedures we do and how that benefits the patients we serve?
Thank you, Liz. So minimally invasive surgery really is a broad term that encompasses the approaches to surgery, which include laparoscopy, meaning making small incisions on the belly and operating with cameras, a robotic assisted laparoscopic surgery where we do similar approach, but use the assistance of the robot for better visualization and optimization of our surgical techniques. And then hysteroscopic approaches, which is where we use a camera and operate really in the uterus through the vagina without making any incisions at all. And so those are our minimally invasive surgical approaches. And as you mentioned, some of the surgical procedures that we would have done traditionally from a more maximally invasive approach with large incisions on the belly would have been things that we would have done, like hysterectomies to remove the uterus, myomectomies to treat and remove uterine fibroids, or procedures where we would operate on the ovaries or fallopian tubes, which would include things like sterilization procedures or procedures where we would treat ectopic pregnancies, ovarian cysts, and the like. And so now all of those procedures can be done through the minimally invasive approaches that I mentioned. And that benefit, as you alluded to, includes less blood loss for our patients, less pain in the postoperative recovery period, shorter hospital stays, and a faster recovery and return to activities of daily living.
That's great. Thank you so much for explaining that to our viewers. I know we have had some kudos from a STARS ranking. We have a 5-star health grades ranking with regard to our hysterectomy procedures and programs. Dr. Burke, would you care to comment on some of the quality initiatives that we have and what that means to our viewers?
Sure. So access to minimally invasive hysterectomy and other procedures is important, but also outcomes and the quality of care that we're providing is paramount for patients and for our medical centers. So health grades is just one way of looking at our outcomes compared to ourselves. So that includes reducing infection rate from hysterectomies and other procedures, decreasing pain and readmissions. And so I'm happy to say that what a 5-star rating really means is that compared to other institutions that may be a lower star, and compared to, for instance, a 1-star rating, we have 65% less complications for patients, which is quite important. On a flip side, it's very important for the patients to know that we constantly look at our data and our outcomes on a monthly basis, and I can assure you that the department and the institution takes your health and your outcomes as a main priority.
Great. Thank you, Dr. Burke. I would like to take a quick minute to put up the QR code and remind everyone that we're happy to take questions from the audience. If you have any questions as we move through the next period of time, feel free to use the QR code or drop them in the chat. Now, Dr. Blaber, I know we have some non-surgical approaches to pain management. Would you care to talk a little bit about those?
Sure. Our minimally invasive gynecologic surgical team also does quite a bit of work with chronic pelvic pain and endometriosis. In fact, we have dedicated office sessions to treat those conditions. As everyone may or may not be aware, it is actually Endometriosis Awareness Month in addition to Women's Health Awareness Month. And endometriosis is a chronic condition where the cells that line the uterus are located in places where they shouldn't be, and that causes inflammation, chronic pain, and issues with fertility. And we, in our chronic pelvic pain setting, really work to or strive to have a multidisciplinary approach to the way we deal with chronic pelvic pain. We work closely with our colleagues in our chronic pain management services, gastroenterology services, urology services, to really have an approach to improve the quality of life of our patients who live with these conditions.
Great. Thank you for explaining that. I'm going to switch now to maternal fetal medicine. In addition to the expertise that we have in minimally invasive procedures and non-surgical pain approaches, Stony Brook Medicine's maternal fetal doctors and nurses treat high-risk pregnancies, and they're truly experts in this space. And they help to specialize in births that are not routine. Dr. Choi, can you elaborate on what that means for the consumers and the patients that are viewing this particular show?
Maternal fetal medicine specialists are high-risk pregnancy physicians. We provide comprehensive care for mothers with pre-existing medical conditions, fetal complications, or obstetrical complications. Pre-existing medical conditions may include diabetes, hypertension, autoimmune disorder, substance use disorder, and twin pregnancies. Obstetrical complications may include preterm labor or placental abnormalities. Fetal complications may include fetal growth restriction and congenital anomalies. So we partner with our patients, their family, and their medical team so we can navigate this unroutine path and make sure that we provide the optimal best outcome care.
Great. Thank you so much, Dr. Choi. I know, again, quality is paramount to the care we provide, and we are constantly looking at ways to improve the experience for our patients, as well as to make sure we have the highest outcomes and quality. Can you talk a little bit about some of the outcomes for our patients and some of those programs?
To say a few, we have 3 programs here at Stony Brook. We were named the Accreta Center of Excellence in 2021. Our maternal fetal medicine specialists are experts at diagnosing placenta accreta spectrum disorder, which is a condition where the placenta abnormally and deeply adheres to the uterus, which can lead to significant blood loss if not managed properly and treated. So once we identify that problem, we take a multidisciplinary approach, and they may include our GYN oncology team with Dr. Burke here today, our neonatology team, anesthesiology, and sometimes even our nursing, interventional radiology, general surgery, and urology teams to make sure that we prepare for a safe delivery. We also have the Children's Fetal Care Program here, where we try to design a customized plan to our moms-to-be and their babies once we diagnose a congenital anomaly. And these congenital anomalies may be anything from fetal conditions like heart defects to brain or renal spinal defects. We work very closely with our program coordinator named Mary Beth to provide one point of contact so our patients have easier access to communication, to programs, to the multidisciplinary subspecialists here during their pregnancy, delivery, as well as their post-delivery period, including into their childhood. Lastly, we also have our maternal opioid maintenance support program, which is also known as MOMS program, where we provide prenatal care for women with opioid use disorder. As we may already know, opioid use disorder has become a significant concern, especially with chronic addiction issues and women who misuse opioids. So these increase your risk of pregnancy complications and women's involvement in high-risk behaviors. So when we identify this problem, we try to make our patient the leader in her own recovery by providing them with education and support, multidisciplinary care, medication-assisted treatment for withdrawals and to achieve treatment success.
That's very helpful. I know in the U.S., maternal mortality rates continue to rise and continue to be a concern for all states, all areas, all communities. So talk a little bit about your opinion on this issue and what do we do at Stony Brook to help improve outcomes and reduce pregnancy-related death?
According to the latest records released by CDC, the maternal mortality rate has risen by 40% in 2021 compared to the previous year. The maternal mortality rate was 32.9 maternal deaths per 100,000 live births, and which is 10 times greater than the estimated rate for other high-income countries across the world. The mortality rate was approximately 1,205 women in 2021 compared to only 861 in the previous year. So this is of grave concern to us right now. We try to, in Stony Brook, before I go to that, the top 3 causes of maternal mortality are cardiovascular conditions, infection, and cardiomyopathy. In Stony Brook here, we are a level 4 regional perinatal center with a level 3 NICU. We are the only regional perinatal center in Suffolk County out of the 17 that exist in New York State. So some of the mentioned programs I had discussed about managing placenta accreta in women with opioid use disorder are methods that we try to reduce maternal morbidity and mortality. But given the rise in the maternal cardiac conditions relating to maternal deaths, we also work very closely with our cardiology colleagues, including Dr. Mann, who is here today, to make sure they have early access to the optimal pregnancy care they can receive.
That's wonderful. Thank you so much for explaining that. And Dr. Burke, do you have any other comments you'd like to share related to the topic?
Sure. I'd like just a little bit. Stony Brook is lucky enough to be the home of the Regional Perinatal Center, which our affiliated hospitals are Good Samaritan, St. Catherine, Mercy, St. Charles, and Stony Brook Southampton Hospital. And what that means is we drive a central repository and central database. We coordinate provider nursing education and simulation, and we support New York State initiatives. And more importantly, New York State initiatives for overall maternal fetal health are aligned with the Healthy People 2030. So the Healthy People 2030 initiatives are to decrease maternal mortality, to decrease primary cesarean sections in low-risk women, to decrease preterm birth, and to increase the receipt of prenatal care properly through women. And I'm happy to say that we're supporting this here. We've submitted a proposal to our Assemblywoman for hopefully support to expand on these programs, and we look to really improve the healthcare of women in Suffolk County in the near future.
Thank you. I have only been at Stony Brook now for about 8 months, and I continue to be amazed by all of the wonderful things that our physicians and our staff do to really improve the quality outcomes for our patients. It's truly remarkable. I'd like to turn now to cardiology. Dr. Mann, can you tell us a little bit about some of the specialized services that we have for women's heart health? There's so many heart health issues. Women, I know, worry more about cancer usually than they do their heart, but a lot of mortality and complication issues come from the heart in women. So can you share a little bit about that with us?
Sure, happy to. So here at Stony Brook, we have a women's heart center as well as a cardio-obstetrics program. In our women's heart center, we focus on really cardiac issues that are more specific and more common in women. So in women, they tend to have a more common form of disease of the heart called microvascular disease. That's disease of the very small vessels of the heart. Spontaneous coronary artery dissection, which is a tearing of the arteries that supply the heart, as well as plain old coronary artery disease, which is blockages of the arteries that supply the heart, and valvular heart disease. And unfortunately for women, they tend to be more profoundly affected by traditional risk factors than men. So we all, are pretty familiar with those traditional risk factors of hypertension, diabetes, elevated cholesterol, smoking, obviously age, nothing you can do about that, family history of premature coronary artery disease, obesity, sedentary lifestyle, and poor diet. But these risk factors tend to be more potent in women. So For hypertension, you have a 1.5 higher risk of having a heart attack. Diabetes, a 1.6 higher risk of having a heart attack, as well as, and smoking, a 1.3 higher risk. So we also, in women, we also, there are also non-traditional risk factors, and some of these are early menopause or premature menopause, and premature menopause is defined as menopause that begins before age 40. Early menopause is in between 40 and 45. Having prior gestational diabetes, hypertension in pregnancy or preeclampsia also increase your risk for coronary disease later in life. And also systemic inflammatory disorders such as lupus also put you at higher risk for having coronary artery disease later in life, as well as depression. And that also tends to be more common in women. So it's very important that we recognize these non-traditional risk factors and try and manage them as best we can. Additionally, at Stony Brook, we have a cardio-obstetrics program. So we work very closely with our colleagues in OBGYN, in MFM. We also work with our OB anesthesiologist to really create a plan for some of our, very sick patients that are pregnant. Mothers that we are, as was mentioned earlier, cardiovascular disease is one of the leading causes of maternal morbidity and mortality. And mothers that have cardiovascular disease also are at an increased risk of fetal growth restriction, premature delivery, and inherited genetic disorders. So what we treat here, along with our colleagues, we treat hypertension in pregnancy, preeclampsia, any of pregnant patients that have any difficulty or problems with the valves of the heart, valvular heart disease, cardiomyopathy or a weakening of the heart muscle, which tends to pose a relatively high risk for these patients, congenital heart disease, which is a kind of a broad term that can encompass many different forms of valvular and, heart muscle disease, as well as diseases of the aorta, which is the main artery that comes out of the heart. So there's also many medications that are contraindicated in pregnancy, and sometimes managing blood pressure in these patients can be challenging, and that's why it's really important to be cared for at a center that has experience taking care of these women and their babies, and really working in a multidisciplinary way to plan the safest delivery for mom and the baby.
Wonderful. Thank you so much for that. I really would like to circle back on a couple of things. We talked earlier about endometriosis and minimally invasive procedures, but I also wanted to ask the panel to address with PCOS, polycystic ovary disease. I think that's something that a lot of women don't realize they have. There are some common symptoms, signs, and I know we've got a lot of expertise in that space as well. So maybe Dr. Burke, would you like to start off on that topic?
Sure. So, we've been supporting an initiative to take care of the comprehensive problems associated with PCOS, and are proud of that. In my arena, what I see is women with PCOS are at an increased risk of precancerous and cancerous lesions of the uterus. So oftentimes we'll see young women who are presenting with difficulty getting pregnant, and they have an endometrial biopsy or a sampling of the uterine tissue, and they're found to have a precancer or a cancer. The good news is we approach this as a potential fertility-sparing treatments, and there are good options for women that have precancers related to PCOS that will allow them to maintain their fertility and have children in the future if that's something they desire. So we take pride in that.
Excellent. Thank you. I know one thing that we also are working on is really looking at our population and really trying to make sure that we have an inclusive environment for all patients, and making sure that they feel that their personal needs and beliefs and views are respected and adhere to what they like and what they prefer. Can we talk a little bit about what we do to help pregnant women who have various cultural concerns or various other concerns in the home or in the community that they'd like addressed, and what do we do to help support them? Dr. Burke, would you like to go ahead and address that?
Yeah, I mean, so from a departmental and a hospital standpoint, all women that are and patients that are pregnant, we will help them enjoy and get the access to care that they need to provide a good outcome. So I would ask, Dr. Choi, can you speak specifically to some of the programs of how we hook women into our care system?
Well, I'd say that we have a very large, diverse group of providers here, and they include our obstetrician, laborist, maternal fetal medicine specialists, as well as our midwives. We have the largest midwifery group in Suffolk County. And each of these patients, if they present to us with a question or concern or any type of cultural question as well, I think we try to guide them to the respective team who would be most appropriate for them if they are comfortable. In certain ways, some of the Asian population patients may come to me and to other respective cultures as well. I think that, through all the different layers of the providers that we have, we do really try to listen to our patients utmost. And it's most important for us that we provide the care that they need and they're very comfortable with it. So there are ongoing efforts right now here at Stony Brook to help with that process.
Yeah, I would make one other comment is sometimes patients learn better in groups, and one initiative that we have through our midwives is centering and providing prenatal care in groups, and where people are supported, can ask questions in confidence, and go through the process together. So we're really excited about expanding the centering options in Suffolk County and giving women the ability to share a shared experience and learning about moving through pregnancy.
Excellent, thank you. I know we have several areas where we really look at prevention. And I know, Dr. Mann, there are several resources available as we think about cardiac issues in women. Would you like to talk a little bit about some of the resources available through the American Heart Association?
Sure. So the American Heart Association has a lot of great information on their website, and in addition to, actually on Stony Brook's website as well. But it really is important for women to be, very aggressive about controlling your risk factors to really achieve and to prevent heart disease later in life. And, we really particularly want to emphasize, especially for these patients that we see in with our MFM colleagues, that gestational diabetes, hypertension and pregnancy really put them at a much higher risk later in life for for having coronary disease. For hypertension and preeclampsia, it's a 3 times higher risk. Early menopause, it's a 4 to 5 times higher risk than the general population. Having depression actually puts you at a 2 times higher risk for heart disease. Smoking, like I said before, is a very high risk, and actually women that smoke on average live 14 years less than women that don't smoke. So if you're on this live stream and you smoke, please make every effort to try and quit and use all the means available that are out there, gum, medication, hypnotism, whatever it is that you feel will help you. But those are really important to try and manage those risk factors. The American Heart Association has something called the Life's Essential 8, and it's really the 8 kind of things you should do for yourself to keep yourself healthy. The first one being eat more healthy, so specifically more whole foods, increasing your intake of vegetables and fruits, eating lean protein, nuts, seeds, using, sparingly non-tropical oils such as canola oil and olive oil. Being more active, that's very important, at least 30 minutes a day, 5 days a week of at least moderate exercise. Not exercising, I always tell my patients exercising is good for you, not exercising is bad for you. Not exercising or being inactive has almost a similar risk equivalent to smoking a pack a day. So really important to do some form of physical activity. I prefer every day, but at least 5 days a week. The third one is quit smoking or vaping. Like I said before, it's the leading cause of preventable death. Getting enough sleep, something probably all of us on this could do a little better at, but aim for 7 to 9 hours per night. Maintaining a healthy body weight, keeping your BMI at around 25 or less, controlling your cholesterol if your cholesterol is elevated. Specifically, the LDL or the bad cholesterol is the one that's most highly associated with coronary artery disease, and also managing your blood sugar. So if you have any issues with your blood sugar, really important to try and modify your diet and avoid those simple carbohydrates like white bread, white rice, highly processed sweets and snacks, sugary drinks. And just to kind of bring in also PCOS to this, having polycystic ovary does also predispose you to impaired glucose tolerance. And those patients also have a much higher risk of progressing to diabetes. So very important to really be aggressive in managing your blood sugar. And then finally, managing your blood pressure. Optimal blood pressure is less than 120 over 80. Anything above 130 over 80 is considered elevated. And I think that's probably about it.
Thank you. A lot of very important information, especially with regard to preventative types of things that we all have control over. I'd like to ask each of you, what one piece of advice would you give to women? We really have been talking about a lot of women's issues, from surgical issues to pregnancy to heart disease. But what is one good piece of advice to help women stay healthy from a preventative perspective? Dr. Blaber, why don't you go first?
I would say that it's important to make time to take care of yourself. I think that we are often very busy and forget about the simple self-care that it takes to stay healthy. And so I would remind everyone to make time to make healthy choices.
I think that's a great one. I know I'm guilty of that. I take care of everybody else before I take care of myself. So I think a lot of women do that. So I can definitely relate to that one. Dr. Choi, what would you say?
I would say that there are many more available resources than what meets the eye. So seek and just continue to try to learn, ask questions when you come to us or even to your friends or neighbors to see what programs are available for you. And one thing today, Dr. Mann was discussing about smoking cessation, but even with smoking cessation, there are so many programs that are available in the community, in the state, that you can reach out to. So you're not alone in this process. And if you need help, just always ask.
Okay. That's wonderful. Thank you. Dr. Burke, what advice would you give?
Right. I have two. One is the cancer part of me says, please get your screening. Mammograms and pap smears save lives. But on a more holistic approach, I would recommend that women engage the Stony Brook medical community. And though we're not a standalone women's hospital, we really are a women's hospital, right? We provide comprehensive, amazing services in all walks of women's life, from the teenage years, pediatric years, through reproductive life and through menopause. And we have a tremendous amount of experts, and we would welcome you, and I would tell them to engage the community and take care of yourself.
Thank you for that. We really do have expertise for women from childhood, pediatrics, birth, all the way through their twilight years. So I think we've got a totally comprehensive set of services that women can engage with. Dr. Mann, we do have a follow-up question that came in from one of our viewers, and I'm going to read what they said. They said, you said that exercising is the equivalent of smoking a pack a day. This person says that's terrifying, which I agree. Can you elaborate on that? And what type of exercise do you recommend the most?
Yeah, I know it's one of those kind of not very well publicized facts, but specifically cardiovascular exercise. So meaning it doesn't have to be anything fancy. It can be walking, biking. If you like to do classes, any of that is good. I really also recommend doing some type of weight training. After age 40, if you do not do weight training, you will lose muscle tone. You'll lose muscle tone. So even if you do, walking or running, if you don't do some weight training after age 40, then you lose muscle tone. So it's important to at least do some type of weight or resistance training. That can be body weight exercises like push-ups, sit-ups, lunges, can be yoga, tai chi, any of that. Can use, bands, weights. You don't have to, become like Arnold Schwarzenegger. It just has to be something that challenges you. The other thing I wanted to comment on, just, the question you had asked the other panelists, for my piece of advice, one of them would be to listen to your body. Women can have atypical symptoms, and especially with the heart. Not everybody has crushing chest pain. Not everybody has like the classic chest pain going to their jaw or to their, left arm. If you don't feel right, please seek medical attention, because women especially can have very atypical symptoms of heart disease.
Yeah, that hits home for me. I know my mother had a heart attack in her 50s, and she was moving a piece of furniture and thought she pulled a muscle, and here she had a heart attack. So that one really hits home for me. I actually saw that, and it really made a difference when she finally sought help and got on a path to prevention. So that was a lesson for me, at least. Any other questions from the audience? Please go ahead and drop them in the chat. I know we've had a couple of questions related to menopause, and I know we don't have a lot of time to address that particular topic today, but for example, Dr. Burke, would you like to comment on that just briefly so that we can give that viewer a little bit of information in this particular topic?
On the hormone replacement?
Yeah.
Yeah, I think that hormone replacement in women has, since I've been training, has gone through oscillations of, hormone replacement is a wonderful thing for women when worked up appropriately and done appropriately. Especially the question was, is it safe and are there benefits? So women that are treated within 10 years of menopause and that are treated at an earlier age and have been worked up for cardiovascular disease do have some long-term benefits. In our patient population, it's definitely symptomatic: hot flashes, vaginal dryness, pain with intercourse, and just general problems with metabolism. So I think if you are screened properly for cardiovascular disease and you are interested in it, please talk to our specialists, as I think it's a wonderful option with women. And I personally believe that some of the data was presented in a way that scared women in the United States and the world away from hormone replacement. I don't know if that really answers the question, but Dr. Mann, I didn't know if you wanted to comment on that as well.
Yeah. So, there was a time when hormone replacement therapy was prescribed, very freely.
Yeah.
And then the study that came out, which really kind of put the kibosh on it and really saw the prescriptions drop dramatically. The major criticism of that study was the average age in the study was 65.
Mm-hmm.
So the women in that study were well beyond menopause. Subsequent studies have shown that women, when HRT is started at a younger age, within the first 10, like you were saying, in the first 10 years of menopause, and again, for symptoms, not for prevention of coronary disease, did much better. And actually they saw there was a 26% lower risk of Alzheimer's and dementia. There was actually a 45% reduction in breast cancer mortality. Transdermal estrogen replacement therapy may have may have improvement in cardiovascular risk as well. So again, it should not be prescribed just for prevention, but if you have symptoms, and coronary disease has been ruled out, then it's definitely, I think the data has shown, more recent data has shown that this is not, that this can be beneficial.
Yeah, and I'd just add to that, I think that's a great summary. I feel like women suffer out of fear. And so when I provide my patients with data that makes them feel a little safer. Almost everybody wants to make their daily life better. And so when we're really talking about symptom control and hormones, very important, again, to get the data, to know what the risks are, and to kind of move forward and not suffer, so to speak, in silence. Okay, it is okay, and we can help you.
Thank you for that. I think that's very wise information, and I think a lot of women should focus on themselves, take better care of themselves, and get that data from our experts. We do have another question that talks about screening. What types of screenings are important, and at what age? Who would like to take that question for us?
I can take that one.
Okay, thank you.
So we begin our cervical cancer screening with Pap smears at age 21. We recommend that we begin breast cancer screening with mammograms at age 40. And the newer recommendations for colon cancer screening are that colonoscopies should begin at the age 45.
Excellent. That's wonderful. Thank you. I think that we've got another comment that has come in, and the question is really around the video, and is the video going to be available? So yes, we will have this available on our platforms on Facebook, YouTube, Twitter, LinkedIn. I know we've shared a lot of information today, and it's hard to remember all of it. So we will definitely have the recording out and available if you'd like to come back and listen to different parts of that. One other question related to women's heart disease. How does that affect and interact with, screenings, and what kinds of heart-related screenings would you say we need to pay attention to?
So, again, your primary care doctor should first, really screen you at least age 40 for your cholesterol. It should be 1 to 2 years after, every 1 to 2 years. Blood pressure, in routine lab work, checking your blood sugar. If you have a very strong family history, obviously you might want to start that screening a little bit earlier. If your patient is a smoker, you may want to start that a little bit earlier. But really being, aggressive with those risk factors. The risk factors that you can't do anything about are your family history, your age. So we can't do anything about those. But the modifiable risk factors like your lipids, your weight, your activity level, your diet is very important. And really trying to avoid highly processed foods, eating healthy takes time. It's actually, it takes a lot more work than not eating healthy. It requires a lot of chopping and, all of that. So, but, I find too, if you, for people that are working, and I do this myself, if you meal prep maybe on the weekend or at the beginning of the week, then it becomes a little easier. You can just kind of pull from things that you've prepped from. But, it is an ongoing effort. It's, oftentimes easier to either order in or, go out to eat. But you tend to eat a lot more healthier if you eat at home. And, if you have high blood pressure in your family, just make sure that you're screened for that. And with a goal of blood pressure less than 120/80. I've had many patients come and tell me that their blood pressure runs a little high. A little high is not good. Every 10 millimeters of mercury that your blood pressure is above 140 puts you at a 20 to 30% increased risk of stroke. So a little high is not good. It puts you at a higher risk of stroke, and treating that blood pressure brings down that risk. So just really encompassing everything. It's not just one thing that causes, coronary disease. But it's a compilation of things. I also see in the comments, cardiac rehab. If you've had any, if you're not somebody that exercises and you've had a cardiac procedure, whether it's a stent or, a valve replacement or even if you have heart failure, we do have something available at Stony Brook and called cardiac rehab. We're only actually one of 2 or 3 places in Suffolk County that have cardiac rehab. And cardiac rehab is a supervised exercise program It's 3 times a week for 12 weeks for an hour. And it's basically like having your own personal trainer. It's really fantastic. You're on a monitor, they monitor your blood pressure, and it's really for, especially for those patients that don't exercise regularly, to get you into a pattern of exercising so that you can continue that. If you don't continue exercising after cardiac rehab, then you lose all of the benefit of cardiac rehab. But cardiac rehab has been shown to improve outcomes after having any cardiac procedure.
Okay, thank you, Dr. Mann. I'm going to do just a quick round robin and ask for any parting thoughts from each of our panelists, and then we're going to close out for today. So, Dr. Choi, what closing thoughts do you have?
We were excited to be here today to meet with you and talk to you about women's preventative care and obstetric care. Feel free to reach out to us at any time. Like I said, for us and on behalf of maternal fetal medicine, we are available to you before, during, and after the pregnancy. So just be aware that we are there for you.
Great. Thank you, Dr. Choi. Dr. Blaber?
I would just like to thank everyone for having me today. And I would say that our minimally invasive gynecologic surgery team is here for you, not just for your minimally invasive surgical options, but also for all of your complex pelvic pain needs.
Great. Thank you. Dr. Mann?
Yeah, I just wanted to say that, I feel privileged to work here, work with a really wonderful group of people and colleagues. If you're somebody that has a complicated pregnancy, we really work very closely in a multidisciplinary way to get you through that pregnancy and in the safest way for both you and the baby. And if you have any just specific cardiovascular needs, we're also here to help and to, as I think Dr. Choi said earlier, just really making time, or maybe it was Dr. Blaber said, just making time for yourself every day. If you're not able to exercise the full 30 minutes, but you could take the stairs instead, try doing that. So just always try and make that little bit of time for yourself so that you can care for others, because we all tend to put everybody else first and ourselves last.
Absolutely. Thank you, Dr. Mann. Dr. Burke?
Sure. First, I want to thank you, Liz, for being able to host the services that we provide for patients in Suffolk County. And second, I am humbled and thank you to our amazing practitioners and the care that they provide for women at Stony Brook.
Thank you, Dr. Burke. I appreciate it. Again, I can't thank all of you enough for being on this live stream with me. You've shared a lot of valuable information. I know this one will be one that folks will come back to and try to review to gather all the nuggets and pearls of wisdom that you shared. So thank you for that and for your expertise. I would also like to let the audience know that if you do want to schedule an appointment with one of our experts, you can call us at 631-444-4686. You can also visit our website at womenshealth.stonybrookmedicine.edu. And don't forget to follow us on University Associates and OBGYN on Facebook at SBM OBGYN. So again, thank you all so much. I know we had some other questions about menopause. Unfortunately, we didn't have time to get to those today, but you have given us a thought for another live stream, and so we will revisit that topic soon. Thank you.